give everyone one more minute before we get started. Okay, it is 12:01 on my clock, so we might as well get going. Thank you, everyone, for being here today. My name is Paxton Bach. I'm the director of the Addiction Medicine Fellowship. I'm very happy to introduce our session today. Today we have with us Dr. Tony Zhao, who's one of our Addiction Medicine Fellows at BCCSU. He's a graduate of the UBC Family Medicine Residency Program with a particular interest in patient advocacy and quality improvement, as well as obviously in the treatment of stimulant use disorder. Tony's additional hobbies include salmon fishing and board game collecting. He's going to be here today to present to us an update on the treatment of stimulant use disorder, which I think is a topic that is very relevant to all of us these days, and something that we're all quite excited to hear more about. So with that, I'll turn it over to Tony and let him take it away. Just to remember, you can save your questions to the end of the session, where we should have time for some discussion, and we can you can flag us and we can unmute you, or just type your questions into the question box. With that, I'll let you take it away, Tony.
Perfect. Thank you so much, Paxton. All right, nice to meet you, everyone. So again, my name is Tony. I'll be talking to you a bit about stimulant use disorder today. So before we start, I just want to respectfully acknowledge that I am a humble guest on the unceded homelands of the Musqueam, Squamish, and Tsleil-Waututh nations here at BC Children's Hospital. There's two main learning objectives that I hope to address through this presentation. One is I hope to help everyone develop an approach to the treatment of stimulant use disorder. And then further to that, we'll sort of look and review and evaluate some of the more recent literature that's been published on this topic. Some background to start. Stimulants is a broad category of substances. The main two that we tend to see and focus on is cocaine as well as methamphetamines. Cocaine comes generally in two forms. There is the salt form, which generally is powder-like and tend to be used via snorting or injection. And then there's also the crack cocaine component, which is the base form. Generally looks rock-like and is usually used by smoking. The picture above there is the regular cocaine form, so the powder form. We are also looking at methamphetamines, particularly crystal meth. It's also been known by names such as crystal, jib. I think here in Vancouver, we tend to hear speed and side used quite a bit as well. This is something that originally was processed and produced from ephedrine and pseudoephedrine, which was previously found in cold medicines, but really now, this can be produced from a variety of chemical means. And lastly, there's amphetamines as a broad category. A little bit information about stimulants as a whole. Their overall effect on the brain is that it increases the amount of dopaminergic actions. And methamphetamines compared to cocaine has some additional properties. Cocaine works to prevent the uptake of dopamine, so whatever dopamine is there has a longer time of action, while methamphetamines does that, but in addition to it, it also further helps release dopamine. It's a bit important to recognize the half-lives for these substances because that does affect the way our patients utilize these substances. Cocaine has a relatively short half-life of around half an hour to 2 hours. So the result is that the effect is shorter lasting, so tend to be used multiple times throughout the day, and intoxication resolves faster. Methamphetamines, on the other hand, has a much longer half-life, around 10 hours, although there is a wide inter-individual variability with regard to this. Patients can use generally anywhere between 2 to 4 times per day, could be more, and intoxication tends to take longer to resolve. How are they taken? Cocaine, as mentioned, can be used either by snorting or by insufflation or injection, and it can also be smoked. While crystal meth, additional to that, can also be taken orally by parachuting, It can be taken rectally as well. Throughout my presentation, because stimulant is such a broad category of substances, I will try to make the points of information I'll be speaking to try to tailor towards which substance. For instance, is it cocaine or is it methamphetamines? And you can see above I made two symbols for these substances. For cocaine, it's sort of the coca leaf symbol. And then for methamphetamines, I'm looking at the crystal symbol, just to sort of help us keep on track of which substance we're talking about. To begin, just want to introduce some background information on the prevalence of stimulants. So stimulants as a group, meaning cocaine, amphetamines, is the second most illicit substance around the world after cannabis use. Now, of course, this is speaking in terms because cannabis is still considered an illicit substance in many jurisdictions. It is, however, only slightly edging out opiates right now. According to the UN drug report in 2019, there's around 67 million stimulant users worldwide versus around 62 million opioid users worldwide. In terms of more focus to the North American population, there is an increasing trend of methamphetamine use. Studies in BC found, back in 2006, methamphetamines was around 19%. In 2017, it was around 36%. And now most recently, a 2021 study looking at the population who was accessing harm reduction services in BC, spread in multiple communities. They found that crystal meth was actually the most frequently reported substance used in the last few days, at respectively 59.7% in 2018 and 71.7% in 2019. So we certainly see this increasing trend of methamphetamine use, particularly in North America and here in BC. There's also an increasing trend of stimulants being found in illicit drug toxicity death. For instance, a recent BC Coroner Service report found that between 2018 and 2020, looking at illicit toxicity death, cocaine was involved in 49% of them, and then amphetamines or methamphetamines was involved in 39% of these deaths. Further to that, the adulteration of the stimulant supply with other substances such as fentanyl has also been on the rise. A BCCSU drug checking data that was published recently, looking at September 2020 to January 2021, so very recent data, found that 4.1% of expected crack cocaine samples was adulterated with fentanyl, while 6.5% of methamphetamine samples was adulterated with fentanyl. So in short, stimulants play a large role in what is being used. There is an increasing trend towards more methamphetamine use here in North America, and there's also an increasing trend of stimulant being found in illicit drug toxicity deaths, as well as adulteration of more stimulants with fentanyl. So beyond the sort of these substance use disorder harms associated, there are particular harms associated with stimulant use that we need to be mindful of. They fall in some broad categories. The first, of course, is the cardiovascular, cerebrovascular ones. So stimulants cause increased heart rate as well as blood pressure, which predisposes to the risk of myocardial infarction, stroke, as well as renal insults. So that's a broad category there. But more so today, I'm also going to touch a bit on the psychiatric harms of stimulant use. It's well known that stimulants can induce as well as perpetuate mood changes as well as psychosis. Some interesting information looked at of psychosis that occurs as a result of stimulant use. And within cocaine use disorder patients, 68% of cocaine use disorder patients mentioned that they had experienced cocaine-induced psychotic symptoms. For methamphetamines, this is a bit more variable. numbers range in the literature from 23 to 76% of users, and a recent 2018 systematic review placed at the prevalence of psychosis post-methamphetamine use to be around 42.7%, so quite high numbers here. And in addition to that, methamphetamine use has also been linked to not just induce psychosis, but to cause persistent, ongoing psychotic symptoms for longer than 1 month. And within this study of 7,000 or so individuals, approximately 20% of participants who were using methamphetamines, crystal meth particularly, 25% of them developed psychosis that lasted more than 1 month. So quite a significant impact here. And of course, depending on how the substance is used, we are also at risk of bloodborne infections such as HIV, hepatitis C. Oh, I'm getting information that says slow internet connection. Hopefully my webcam is still on. I'll try to keep my webcam on, but if there's any issues, please just let me know. Information about the DSM-5 criteria for substance use disorders. I think most of us are familiar with this, but I just want to emphasize again, when we're diagnosing these disorders, we want to focus on 4 main categories, which is impaired control, impaired function, risky use, as well as tolerance and withdrawal. So we use these things to look at to make a diagnosis. The information I'll be speaking to you today overall has been well reviewed. There is a recent systematic review that was a review of reviews done in 2019. This had looked at the publications prior to that. I will, however, cover some additional publications since then that are of interest, particularly with regard to psychostimulants, antidepressants like mirtazapine, as well as a combination of naltrexone and bupropion. So a quick summary before we get into the nitty-gritty details, but essentially I think some of the main takeaways is that number 1, contingency management does work, and we'll look at the information for this. And then we'll dig into some of the more information regarding the 3 that I've outlined there. So first, what is contingency management? So in contingency management, participants enter a program where they receive something of value, then this is usually a gift card or a voucher as a reward for achieving a specific goal that they have come up with. Most commonly, these goals are looking at achieving a negative urine drug screen for stimulants. And in most of these cases, there is the employment of a variable reward system. For instance, what I've seen here at St. Paul's is that a patient would set a goal for themselves. If they achieve their goals, they get tickets, and then those tickets are placed into a draw. And then depending on that, they will get a reward. And some of the gift cards range anywhere from $5 to $100 in value. So what is actually the evidence behind psychosocial treatment, especially like contingency management? So this has been well reviewed and studied. The most recent review of reviews looked at 6 previous systematic reviews, and the main one that had the most information is this systematic review published in 2018, which looked at multiple different psychosocial therapies, and specifically the main ones they looked at was contingency management alone, contingency management plus other psychosocial therapies such as cognitive behavioral therapy, CBT, or community reinforcement approach, or CRA, and it also looked at some pharmacotherapies as well. The short form is that contingency management, either by itself or with other add-on therapies, consistency resulted in positive ramifications for the patient, particularly in terms of decreased positive urines. And this was shown to be effective for both methamphetamine use as well as cocaine use. So we'll take a closer detail at this. So this is from the 2018 study. This systematic review looked at 50 different RCTs spread across 12 different psychosocial interventions versus treatment as usual. I think the main ones I want to focus our attention to is what performed the best was at the very top there, contingency management plus a community reinforcement approach. This was the only intervention which resulted in consistently positive abstinence patterns at both the 12 weeks mark, at the end of treatment for whatever the studies we're looking at, also at the longest follow-up date for the studies that were looked at. So this was what performed the best. And of course, what you're looking at there is the odds ratio. And very briefly, the odds ratio is actually quite high for the 12 weeks mark. It was at 7.6 in favor of abstinence. And then contingency management by itself was set a little bit further below that. It was quite, the odds ratio was quite in favor at 12 weeks and at end of treatment, but unfortunately at the longest follow-up had fell off a little bit. However, the summary of this is still that contingency management does work, and it works really well, especially if combined with community reinforcement approach. And just some information on community reinforcement approach. This is sort of where a broad-based behavioral intervention approach, where we look at the patient's reasons for using substances. A therapist often works with them to identify things that they can improve in their social setting, for instance, in their relationships. It looks at their vocations, like what kind of jobs you can do, and it also looks at recreational purposes as well. So it's a very quite broad encompassing behavioral approach in terms of treatment. And the number needed to treat that was calculated from this contingency management plus community reinforcement approach for promoting stimulant abstinence was a number needed to treat of 3.3, which is quite incredible. I do want to mention, however, that a lot of the studies for this systematic review, a lot of the studies that I looked at were focused on cocaine use disorder patients. In fact, 76% of those trials were looking at cocaine use disorder patients. So less of them were focused on methamphetamine use. We just have to be mindful of that. Now, what about cognitive behavioral therapy by itself? So again, this was looked at the 2018 systematic review as well. And unfortunately, CBT alone did not result in any significant benefit in terms of abstinence at 12 weeks, at end of treatment, or at longest follow-up. But it did show a benefit in terms of promoting in terms of decreasing the dropout rate. So having said that, I think in many other substance use disorders, CBT is what we generally go to as our first option for psychosocial therapies. And in stimulant use disorder, we really do have to keep in mind that contingency management is what we should be pushing for. All right, so now that we finished looking at psychosocial therapies as a broad group, we'll take a deeper detail looking at medications. We'll start off with antidepressants. So antidepressants, there's a broad categories with regard to this. And there was a good Cochrane study done in 2011. Here they looked at 37 different studies with more than 3,551 different participants. And what they really focused on was, does antidepressants versus placebo increase in statistically significant difference in terms of abstinence? Now, unfortunately, the answer was no. Despite looking at multiple different antidepressants, including both SSRIs and non-SSRIs, they did not see that benefit. Now, in terms of crystal meth, however, this was done with a different systematic review by Chan et al. In 2019. And again, similar to that, there was 4 RCTs, 590 different participants. And again, antidepressants did not show a significant difference for abstinence from methamphetamine use. Now, I do want to go over some this newer published studies looking at mirtazapine, however. So there has been 2 studies really published on mirtazapine and reduced methamphetamine use. The first one, which done was in 2011, and the second and more robust and replication study was done in 2019, which was not included in the Cochrane review I just mentioned. Hence, this is new information. And broadly, what this study was looking at was, does mirtazapine reduce methamphetamine use in participants? So how this was designed is this: it was a San Francisco-based population. They had so So they had 120 different participants for this larger replication study. They were all men who have sex with men. So what their inclusion criteria was, it was cisgender men, transgender men, or transgender women who have sex with men. They had to be diagnosed with a methamphetamine use disorder, and they also had to be actively using methamphetamines to be eligible. The treatment duration was 24 weeks, and they looked at the intervention group, which was mirtazapine 30 milligrams a day versus placebo. And what they looked at is they tracked the number of negative urine drug screens throughout this duration. And the relative risk there, as you can see, is that at post 12 weeks, at 24 weeks, and also at 36 weeks, which is where their longest follow-up was at, there was decreased positive urine drug screens for methamphetamine use. So this suggests that there was decreased drug use during this period of time. However, having said that, there are several limitations to this study. Number one, the smaller sample sizes. The initial study was N of 60, and the larger replication study was N of 120. The participants was in a very particular category. They were all men who had sex with men. So this might limit our generalizability to the rest of our population that we work with. The study was not powered to detect differences in abstinence. So what we can translate to is that mirtazapine does reduce positive urines. And it also excluded patients with major depression. So some see this as actually a benefit because mirtazapine is an antidepressant. And there were concerns that perhaps the benefits of this was that it was depression that was underlying, that was actually being treated, and hence participants were using less methamphetamines. So our authors argue that because they excluded patients with major depression, perhaps this was the effect was separate to the treatment of depression symptoms. There's also concern regarding the low medication adherence rate, particularly I think the medication adherence rate was around 30%. And the authors argued that this may actually be a strength of the publication because it sort of mimics what we can expect in clinical practice in terms of adherence. So overall, antidepressants as a category, most of the larger studies like the Cochrane review shows that antidepressants does not increase abstinence in stimulant use disorder. However, there is this initial, this new study which shows that mirtazapine particularly may decrease methamphetamine use. Next, we're looking at dopamine agonists as a group. So it's been hypothesized that dopamine agonists, which increase dopamine levels in the brain, may reduce cravings and also withdrawal effects that stimulant users may have, and hence serve as a way of treatment. We do have some studies on dopamine agonists so far. The main one is this Cochrane review on dopamine agonists only in the setting of cocaine use. There has not been any significant studies done on dopamine agonists in methamphetamine use. So this was 24 studies, 2,147 participants, and the summary was that they could not find any improvements in terms of abstinence rate or severity of the dependence or dropout. So unfortunately, no significant changes, no significant benefits here. The next set is antipsychotics. So it's been hypothesized that perhaps the dopamine blocking properties of antipsychotics might be effective in counterbalancing some of the increased dopamine transmissions that may occur from stimulant use, and also the atypical antipsychotics may have a role on the serotonergic system, and hence as a result of that, perhaps aid in stimulant use disorder management. Here, in terms of cocaine use disorder patients, there was a Cochrane review done by Minozzi in 2016, and what it found is that unfortunately antipsychotics did not have a significant benefit in terms of abstinence. But they did notice that antipsychotics did reduce the dropout rate from these studies. In terms of crystal meth or methamphetamine use, Chan et al. 2019 looked at this. There were only a few studies as part of this systematic review, specifically 5, and they did not find any benefits in terms of antipsychotics on methamphetamine use in terms of abstinence, reduction of use, or retention in treatment. So again, it appears that antipsychotics does not generate any significant benefits stimulant use disorder. Anticonvulsants as a group has also something that's been studied. The most conclusive study so far comes from Minozzi in a Cochrane review in 2015. Here we are looking at 20 studies, more than 2,000 participants, and again looking at a variety of different anticonvulsants like carbamazepine, gabapentin, lamotrigine, phenytoin, and also topiramate. They did not find any statistically significant difference between placebo and anticonvulsant in terms of abstinence or dropout rate. It is interesting to note, however, that shortly after that Cochrane review was done, there was a publishing of a systematic review that's very much focused on topiramate as an agent. Here they looked at 5 different RCTs with an N of 518. And within this, there was some limited evidence that 2 of the 5 studies show that topiramate was associated with increased continuous abstinence. However, when you do look at sort of the details of the 2 studies that were included in the systematic review, the first study that showed positivity had an N of 40, so quite a small study. And the second study, which was looking at, I think it ended up around 120, looked at topiramate in comorbid cocaine and alcohol use disorder participants. So topiramate is an agent that's been used in the treatment of alcohol use disorder. So whether this is particularly focused just on whether topiramate's effect was more so on cocaine or whether it was alcohol use disorder that was being treated, and hence reduced cocaine use in that regard is difficult to assess. But there is some limited evidence that topiramate may decrease, may help with abstinence for cocaine use. Our next group that we'll be looking at are the psychostimulants, and I think this is really, what has been quite interesting, especially with some more recent developments in literature. I'll first go over the existing Cochrane review results, and then we'll talk about the new systematic review that came out in just a year ago. So in terms of psychostimulants and cocaine for the treatment of cocaine use disorder, Castells et al. A Cochrane review in 2016 took a detailed look at this. 2016 took a detailed look at this. This was 26 different RCTs and 2,366. We looked at a broad number of different psychostimulants, including things like bupropion and modafinil, some that had lower agonist activity than what we're used to seeing today. The overall summary and conclusion of the study is that there was very low level quality evidence that psychostimulants improved sustained cocaine abstinence. The study couldn't really tell whether it had helped patients achieve abstinence or whether it was patients who had achieved abstinence having a more sustained duration. So overall, the evidence is low for this. They did, however, find that within the proportion of patients who achieved abstinence, there was a particularly stronger effect for those participants who had a concurrent cocaine and heroin use disorder, and who were also maintained on methadone. And you'll see this as something that we'll see come up in future studies as well. In terms of psychostimulants and methamphetamine use disorder, this is a lot less studied, but there is a Cochrane review that was done. This was done by Perez Mana et al. In 2013, and here they have looked at 11 studies with an N of 791. This is sort of a little bit more older study, and there they looked at psychostimulants including dextroamphetamines, bupropion, methylphenidate, and modafinil, and at that time point, they did not find any significant difference in either abstinence or reduced use or or more negative urines. So what is new? Well, what's new is this new Tardelli paper that was published in 2020. This is a systematic review, and this, for the first time, pooled the data that existed for cocaine use disorder and methamphetamine use disorder together. So as you can tell, the Cochrane reviews before was separated into each use disorder, cocaine and methamphetamine, but this one pulled the data together. And also, this systematic review restricted to interventions that were considered to have the most agonist activity. For instance, here we're talking about methylphenidate, amphetamines, as well as they did add on board modafinil. They looked at a total of 38 different trials, the majority of which were still very much focused on cocaine, 26. So again, to confirm, just to reiterate, most of the evidence so far on psychostimulants has been done in cocaine use disorder patients. The number of participants they looked at was 2,889. Some important things in terms of inclusion criteria, exclusion criteria. So a lot of the studies that they looked at here excluded participants with severe psychiatric illnesses. So that included any mood disorders, including depression and bipolar, as well as psychosis. And also the meta-analysis did not pool the side effects that were found in these various different RCTs. So we really don't have a good idea of the side effects of what these psychostimulants are. Now, what did this systematic review look at? Well, it looked at a few things. Number one, they looked at drug abstinence, and they defined this as 2 to 3 weeks of sustained abstinence. They also looked at the percentage of drug-negative urines across the trial. And then lastly, they looked at retention in treatment. The outcomes of interest were limited to these because there was a large heterogeneity to the number of studies that was looked at, but these were sort of the information that was almost always included in the studies. So let's take a look at the results. So the results mainly found what was new is that they found the psychostimulants together as a group for both cocaine and methamphetamine together as a group increased the rates of sustained abstinence. So this is something that is new that was not shown prior. And also, it also increased the duration of abstinence as well. So it sort of clarified the picture that was initially alluded to in the previous Cochrane review. Now, when you do look at the information of this in more particular detail, you'll find that the greater amount of statistical significance was found with regard to prescription amphetamines using the treatment of cocaine use disorder patients. And as you can see here, the relative risk is much higher. They unfortunately did not find any effect on retention in treatment within these populations. They did do some subgroup analysis in this paper. What you're looking at here right now is when you spread the participants into either cocaine use disorder patients or methamphetamine use disorder patients. The top one is cocaine use disorder and the bottom is methamphetamine use. And what you can see is that what's really pulling the overall result away from the null into the statistically significant category comes from those in cocaine use disorder patients. So again, while the study overall was on stimulant disorder as a whole, the results really are more positive for cocaine use disorder patients. In another subgroup analysis, they looked at the medications, so the agonists that were used. Here we're looking at the very top as a category with the prescription amphetamines. In the middle, we're looking at modafinil as a group, and then looking at the bottom, there you have methylphenidate. Again, what you're seeing here is what's pulling away from the null and what's causing the most statistically significant benefit was the prescription amphetamines. And the authors do mention that it looked like dextroamphetamine was particularly the one they looked at. They had also done some subgroup analysis into co-occurring disorders. So again, they did not include any patients with psychiatric illnesses, so they did not do any analysis into depression or psychosis. But they did try to track the number of participants who had ADHD or an opioid use disorder. And when they were looking at ADHD, what they found was that psychostimulants as a group provided significant benefits in participants without an ADHD diagnosis. while there was no benefit in participants with a comorbid ADHD diagnosis. And how the authors suggested this was a finding, they hypothesized that perhaps a participant with ADHD and, for instance, a stimulant use disorder would need agonists in a much higher doses than someone who didn't have ADHD, and hence because of the study limitations in the doses that were looked at, they did not have a result. So that was their hypothesis of how that happened, why there was not a benefit here. In terms of opioid use disorder, so what they found is that psychostimulants gave a robust response in terms of abstinence in participants with a comorbid opioid use disorder, while no benefit was found overall in participants without a co-occurring opioid use disorder. But they did do some more subgroup analysis into here as well, and what they found is that when you restrict the agonist treatment to just amphetamines alone, both those participants with an opioid use disorder and without an opioid use disorder had a statistically significant difference in terms of their abstinence chance. So this result is something that is similar to that found in the previous Cochrane review, which is that for a participant who has an opioid use disorder and a stimulant use disorder, psychostimulants tend to have a greater effect. And I guess the new information found in this study is that when you do look at the psychostimulants inside that subgroup analysis, again, the amphetamines have the greatest effect. Dosing wise, so they also look at subgroup analysis into this as well. They separate them into low dose and high dose. High dose essentially consisted of dextroamphetamines in the 60 milligram per day category or higher. And what they found is that the higher doses of agonists resulted in a statistically significant benefit, while those below that did not, in terms of promoting abstinence. Overall, highlights from the study. So this study shows, for the first time, with some good level of evidence, with greater level of evidence, that psychostimulants, particularly dextroamphetamine, promotes in cocaine use disorder patients drug abstinence, extended duration of said abstinence, and also reduced cocaine use throughout the trial. They found that more potent agonists like dextroamphetamine work better than less potent ones like modafinil. Higher doses work better than lower doses. And they did do some number needed to treat calculations as well. So what they found is that when you were looking at the subgroup analysis for cocaine use disorder patients, the number needed to treat was 7. And within the co-occurring opioid use disorder patients, the number needed to treat was 8. And they mentioned that, these are numbers that are comparable to the utilization of a camprosate or naltrexone for alcohol use disorder. But again, I think while these study results are promising, I think we do have to be aware of the limitations of the study, which is again that number one, they did exclude a lot of the patients who have severe psychiatric illnesses such as psychosis. And we have to be mindful of the target population that we're working with, where this is more prominent. So whether this is actually generalizable, we have to be aware of the risks of our prescriptions. And secondly, they did not look at any sort of the side effects, and they did not pool those together. They did make a comment on the fact that some of the sort of behavioral side effects included increased agitation, trouble sleeping. However, they didn't actually look at the details of those, and they did also not comment on, for instance, cardiovascular disease risks. Broadly speaking, we don't really have good evidence for our particular population in terms of these risks. But if you look at the ADHD population who have been treated with prescription stimulants, what you can find is that there is a risk of increased psychosis as well as cardiovascular concerns. For instance, one population study found that within participants who were started on a prescription stimulant, 1 out of 660 patients could experience new onset psychosis, and this is against for ADHD treatment with stimulants. And then from a cardiac perspective, while some studies have shown that overall within a healthy individual, prescription psychostimulants are relatively safe, we do just need to be aware of the potential cardiovascular ramifications, especially in someone with, for instance, unstable heart disease, untreated or unstable hypertension, as well as those with congenital heart disease or arrhythmias. So we spoke a lot about the treatment of cocaine use disorder throughout this lecture, and how psychostimulants that I just presented before was mostly focused on cocaine use disorder patients. I want to present this paper now that is a very recent publication from 2021, looking at what may be somewhat promising for methamphetamine use disorder. So this one, they looked at bupropion on naltrexone as combination treatment. So bupropion is a stimulant-like antidepressant, so it's been hypothesized that this may have some ability to decrease some of the cravings and withdrawal associated with stimulant use. And then naltrexone, which is widely used in a variety of substance use disorders, such as alcohol, can have some properties to attenuate the reinforcing effects of substance use and cravings. So using those hypotheses as a mechanism of action, they wanted to study this combination. So this study looked at 403 participants. It was a multi-site, double-blind, two-stage, placebo-controlled trial with an interesting sequential parallel design. I'm not going to go into too much details explaining that design, but essentially it's a design process for a study that is often found in psychiatric medication studies. And one of the benefits of said study type is that it enhances the likelihood of detecting a treatment efficacy. And when we do look at the next figure, we'll see what they mean by this two-stage parallel design. The intervention group consisted of extended release naltrexone at 380 milligrams every 3 weeks. So again, this is injectable naltrexone. We do not have this available in Canada right now. And then in combination with that, you have oral extended release bupropion, 450 milligrams per day. And what they did is that they started at 150 and up titrated to 450 in a matter of 3 days. So that was a combination treatment as intervention. The inclusion criteria is that participants had to have moderate to severe methamphetamine use and was also actively using methamphetamines. They did not exclude particularly participants with psychiatric illnesses. However, they did say they looked at those on a case-by-case basis and made a decision. They did not publish any population demographics with regard to the prevalence of psychiatric illnesses in the participants that was looked at. Their outcome was looking at the negative urine drug samples, particularly because this two-stage trial, there were stage 1 and stage 2, each of 6 weeks for a total duration study of 12 weeks. And they were looked at is during the last 2 weeks of each treatment stage, participants would have 4 urine samples done, and the outcome would be 3 out of those 4 urine samples to be negative. That's what they consider to be a successful outcome, to have 3 out of 4 negative urine samples during the last 2 weeks of each treatment stage. So let's look at some of their results. As you can see here, the very bottom is chronicity in terms of weeks, starting from 1 to week 12. And from the top there, and the y-axis you have is the percentage of negative urine drug screens. So in the beginning, there are 400 different participants were split into around 100 participants who went onto the naltrexone bupropion group, treatment intervention group, and then 300 or so in the placebo group. At the end of the first stage, with those in the placebo group who did not have a response, were then randomized again into continuing to be in the placebo group, or they were now on naltrexone and bupropion intervention. And again, you can see here, as time goes on in each of the treatment stages, the number of negative urines does increase overall. So what they looked at was the weighted average response across the 2 stages. So what they found was that when you combine the effects of the 2 stages together, those participants who were treated with naltrexone and bupropion had 13.6% positive outcomes. And then those with placebo had 2.5%. So for overall treatment effect of 11.1% more negative urines. So what they generalize this for is that if their outcome was a surrogate marker for abstinence, this may suggest perhaps increased abstinence or at least a minimum more negative urines. However, we do have to look at some of the limitations of the study as well. Number one, it is a study that is very much had high adherence rate because patients were seen twice a week and were also on medications that were injections with pill counting as well. So whether you can generalize the adherence of the study and to an actual population of what we can use in clinical practice can be difficult. So overall, what we have spoken about so far in terms of treatment for stimulant use disorder, the largest body of evidence that still exists is supportive for contingency management. I think this should still be what we reach to for when we first start, and it's only in the absence of effect, or maybe if we're not able to offer contingency management, that we should then be thinking about some of these pharmacological interventions, because the evidence for those are still not at the same level. With regard to pharmacological interventions, the most promise is seen so far is for psychostimulant agonist therapy. However, even for this one, the evidence so far is quite mixed, with only a single really positive meta-analysis so far. When we do break stimulant use disorder down into its two categories of cocaine and methamphetamines, for cocaine use, we find that psychostimulants is really what has had the biggest evidence in this category. But you may also look at topiramate for some very preliminary evidence. In terms of methamphetamine use disorder, in terms of pharmacotherapies, we looked at the bupropion and naltrexone combination just right now, but also you can consider mirtazapine in terms of reducing methamphetamine use. Again, both of the studies that we looked at for the combination treatment of bupropion and naltrexone, as well as for mirtazapine, have a lot of caveats. For instance, the bupropion and naltrexone combination, we don't actually have the injectable naltrexone available to us right now. And also for mirtazapine, it is for reduction in using a very particular subgroup of patients, men who have sex with men. And right now, we're still lacking evidence in terms of benefit for psychostimulants in methamphetamine use disorder. Some clinical pearls for contingency management. I just want to draw attention to where this is available right now here in the Lower Mainland. In terms of Vancouver Coastal Health Area, contingency management can be accessed through the RAC at St. Paul's, Rapid Access Addiction Clinic. It can be also accessed through 3 Bridges, and I've been told that it can also be accessed through the Pender Community Health Center and the Downtown Community Health Center. So the more in the Fraser House area, we're looking at the Redfish Healing Center, as well as the day evening weekend program at Creekside Withdrawal by Surrey Memorial Hospital. My presentation today was not focused in terms of psychostimulant safe supply prescribing. For that one, I think it's a much more different conversation, and I think for that one, we'll draw you to the information found at the BCCSU pandemic prescribing guidelines. These are my works cited, and thank you for attending, and open to any questions.
Thanks, Tony, for a very comprehensive review of the evidence, especially some of those newer papers. I think that was a nice overview. We already have some evidence from some questions from the audience, so I'll just read out the questions and we'll go from there. So we have a question here saying, sort of asking for a little bit more clarification on that Tardelli trial and your conclusion on psychostimulants. So the question is it fair to say that psychostimulants may not work for meth if they really haven't looked at that in a study? It looks like the study is primarily focused on cocaine. Do you want to comment just a little bit or reiterate kind of the composition of the studies included in that meta-analysis?
Yeah, of course. So again, I think what the Tardelli paper draws attention to is the sort of really the lack of evidence we have, or the lack of studies that's been conducted so far looking at methamphetamine use disorder and as well as psychostimulants in the treatment of that. As mentioned here, the majority of the trials in this systematic review was looking at cocaine use disorder patients, and very few of them were actually looking at methamphetamine use disorder patients. And something that the author was actually drawing attention to is that because of this lack of study into methamphetamine use disorder patients, they were actually suggesting that more robust and well-designed studies in this area need to be done before we can really inform whether this has an effect for methamphetamine. So I guess really it's not that I guess it's hard to say that it doesn't work. It's more so we don't have the evidence to really evaluate it in a for sure manner to make a conclusion right now. Perhaps with more studies on the horizon, which I believe there are ongoing ones, we will know more information.
Thanks, Tony. And yeah, I can add to that. There's a relatively large Australian trial underway on lisdexamphetamine or Vyvanse, which hopefully we may see results on as soon as next year. Next question from Victoria. This is a good question. So again, going back to the Tardelli paper, any insight on why you think that high-dose psychostimulants are actually less effective as treatment in people with the diagnosis of ADHD? That seems a little counterintuitive, and I'm wondering if you know anything more about that.
I'm sorry, I probably couldn't personally tell you more because I don't work as much with patients with ADHD particularly. But what the authors essentially hypothesized in their publication is that, and this is a hypothesis, really, they didn't provide any evidence in terms of why this may be the case. But their thoughts are for participants who has an ADHD diagnosis and further has heavy cocaine use on top, they are thinking that those participants might need a higher dose of agonists to achieve the same effect as someone who does not have ADHD. I'm unsure how they came to that hypothesis. That was something that another study they had quoted as sort of served as the hypothesis, but I did take a quick look at that and I didn't find any really convincing information to share here.
Excellent. Okay, this is more of a comment than a question. Just thanking you for an excellent webinar and mentioning that, Tony, you briefly referenced this webinar speaking more around studies on psychostimulants for treatment rather than as a form of safe supply, and requesting that consideration in the future to do a webinar specifically on that, which I think is a really great idea and something that I think would be of wide interest. So I'll take that one away as something to think about for the future. So we still have a few more minutes while people are gathering their thoughts. If there's any more questions, I'll ask you, Tony, then. So in your experience, if somebody has to walk into the clinic that you're working in right now with crystal meth use disorder in isolation, any particular ideas on how you might approach that, or based on kind of the review of evidence that we have so far, how would you approach that situation?
Right. So I think number one, depends on, you mentioned this part, in this case, the patient is crystal meth in isolation without an opioid use disorder. I forgot to mention one of the drawbacks of the naltrexone and bupropion combinations that it does have naltrexone. A lot of our patients have a concurrent opioid use disorder, so just be mindful of that. This may not be the best treatment for that. So having said that, if they do present with crystal meth use in isolation, I think my first reach to would probably right now be mirtazapine because it's a relatively safe medication, and the evidence for reduced methamphetamine use with it has been shown in 2 studies so far. And I myself have started this in a few patients to some benefit. Having said that, there has been multiple patients I started this on who's told me it made no difference for them. If having tried mirtazapine and they did not have a response to it, then I may consider a combination of naltrexone and bupropion. But again, keeping in mind the study was done with injectable naltrexone, and really an estimate of how much oral naltrexone to give would be an estimate rather than a true assessment. So I would then, in those participants, if they fail to respond to mirtazapine, consider naltrexone and bupropion together. And of course, underlying all of this, is important to mention not to forget about the psychosocial therapies, because again, they are the first line. So contingency management, if it's something I can get for them, I would definitely try to get them engaged in that.
Okay, thanks, Tony. We have another question here. This is a good one. This is a little bit about methodology. A question. Can you comment on the conflation of treatment retention as an outcome in it's often reported in these trials with actual study retention? The comment is that seems to largely require daily visits, no pay for participants, although that's usually not the case. Generally, participants are remunerated for participation in these trials, as well as a low standardized dosage of psychostimulant. So that idea is study retention actually an accurate reflection of treatment retention in real life?
Right. Can I just clarify? I guess we have to clarify because there were so many different trials we looked at. So you have to look at each one really individually. For instance, if you're looking at the bupropion naltrexone trial here, if you look at the methodology of it, this was done with a heavy amount of, for instance, follow-up twice per week. So in those cases, I would be expecting a high adherence rate because of the way the studies was designed. But when you look at, for instance, in terms of this paper here, looking at psychostimulants as a whole, as a systematic analysis, there was a great amount of heterogeneity to the studies that RCTs were looked at. I think it'll be very difficult for me to answer that question to say, if that's reflected or not, because you really do have to look at every single detailed study and how they were done. But the overall, what they found was that they did not find an improvement in retention in treatment. I think I would have to look at each of these methodology in a bit more detail before I can give a really for sure answer for that question.
I mean, I think it's a really good question. And, unfortunately, within the confines of a randomized control trial, it's really all you can comment on, but it's important to recognize that distinction. I think just because you're retaining or not retaining somebody in a study doesn't necessarily provide a reflection of real life outcomes. So that's an excellent question. And we have time for maybe one or two more. So here's another question. A great overview of contingency management and pharmaceutical treatment to promote abstinence. Is there any significant evidence on the efficacy around risk mitigation regarding stimulant-related overdoses or overdose deaths?
Oh, I think that's a very contentious topic, and I know that would definitely come up. So again, I think in terms of I think what we're looking at here is the pandemic prescribing guidelines of the safe stimulant supply. I do believe there is an article or publication that's going to come out in terms of that. I don't think I should be maybe share that information here right now. I could just look at preliminary information, but I think that's something to look at that's coming out soon.
Yeah, there's a clarification here. They're referring to as an alternative safe supply in the case of access barriers. So maybe this is around COVID isolation or maybe rural or remote settings. But I think you're correct, Tony. It's an excellent question and one we're all waiting with bated breath. And I expect there is maybe some data to come out around our pandemic prescribing in the next few months that hopefully will provide more clarity there. So, 2 more minutes. Yeah, open it for any last rounds of questions. Otherwise, if there are no others, Tony, I really thank you for presenting such a topical subject and a thorough review of that recent literature. I think this is, we did draw a larger audience than average today, which is just, I think, reflective of how much interest there is in this area and how much of an appetite there is for more information. So, I hope that we are able to answer these questions more thoroughly in the near future. But I thank everyone for coming. This is our last What's New addiction medicine presentation of 2021. So we'll see you all back in the new year. And thank you again, Tony. Take care.
Thank you so much.